Hello, my name's Alex Scrivens. I'm a final year neonatology trainee in Oxford in the UK. I'm also not a haematologist. I don't have anything to declare, but if you've seen the state of the doctors' strikes in England at the moment, if you would like to give me money, that would be absolutely fine. So, yeah. Excellent. All welcome. No questions asked. So I'm going to talk a bit about red cell transfusions. I'm going to talk how we got here to where we are at the moment in terms of the big things like transfusion thresholds and volumes. I'm going to show us where we are, where we think we are in Europe at the moment. I'm going to pick out a few little controversies, and we've got a few Slido polls in there. And then at the end, I'm going to show you some of the work in progress that we've got at Oxford at the moment. I'm going to focus on preterm babies, on babies with subacute or chronic anemia, rather than those who are acutely bleeding at the moment. And I'd make no apologies, I'm going to leave you probably with more questions than answers today. So packed red cell transfusions, why do we do it? We assume that when we give babies extra red cells, we give them more oxygen carrying capacity, and we hope that that may translate to more clinical stability, recovery from whatever it is that we're treating them from at the moment, maybe less oxygen requirement if they're needing that. We're also hoping that they're going to have less acute anemia and fewer consequences potentially of longer term anemia. And we know that a lot of our babies who go on to graduate from NICU end up back in PICU, and that may even be worse if they've left us very anemic. And finally, they look pinker after a transfusion, and who doesn't like their baby to look a bit pinker? But along with benefits, there's always risks. Multiple donor exposure is the most frequently quoted risk. Transfusions are relatively safe, particularly in more developed countries, but we don't totally eliminate the risk. As mentioned yesterday by our ophthalmology colleagues, we're transfusing adult hemoglobin, adult packed red cells of varying ages into babies who are used to having fetal hemoglobin. And that may in itself bring risks, particularly, as we said, with oxygen availability yesterday in terms of ROP. We touched on briefly a few minutes ago the fluid shift as well involved in giving these babies big volumes of fluid. So potentially 15 to 20 mils of extra fluid going into a baby whose body system can't auto-regulate flow to the brain. Could that be a bad thing? And we know that there's adverse reactions. We report these under a system called SHOT, Serious Hazards of Transfusion, in the UK, but the reports for neonates are actually vanishingly rare. And a question that's come up recently is, are we underreporting these? And we know there are associations with multiple transfusions with poorer outcomes and conditions like NEC. I'm going to talk in terms of liberal and restrictive thresholds. If you start talking about high versus low, it gets a little bit confusing. So if you talk about having a high threshold for doing something, often you mean waiting a long time to actually do it. Whereas if you talk about a high red cell transfusion threshold, potentially you may mean a higher number. So I'm going to talk in terms of liberal thresholds, meaning a higher number, being more willing to transfuse babies, and restrictive thresholds in terms of lower numbers, waiting until their hemoglobin or hematocrit runs lower. Looking back, how we got here, so several large trials, many coming out of the USA. The Iowa trial, right back in 2005, trialed restrictive versus liberal threshold in a small number of babies and found, unsurprisingly, that you gave more transfusions if you were looking at more liberal thresholds. But interestingly, they found in the restrictive group that there were more parenchymal hemorrhages and more incidents of apnea. So they went on to do a similar trial in 450 babies and looked at the outcomes of the major complications and death before discharge, and found that there was actually no difference between the liberal and restrictive thresholds. So people started moving towards the more restrictive thresholds, thinking that giving multiple transfusions may be a bad thing for babies. And then back in 2020, which seems a long time ago now as we're in the grips of a pandemic, but two large red cell trials happened, and many of you in this room may have taken part in the ETNO trial, or anyone from the United States in the TOP trial. Very similar trials run concurrently. ETNO was run in mostly Central Europe with a large proportion of the babies coming from Germany. Restrictive versus liberal thresholds and over 1,000 babies, looking at the primary composite outcome of death or neurodisability at 24 months, as Dr. Moore mentioned recently, and the TOP trial running very similar liberal versus restrictive thresholds in the USA in very similar populations of babies, but giving slightly higher volume in the ETNO group. And both studies, interestingly, found that there was no difference in death or neurodisability at 24 months. And so concluded from that, that using the more restrictive thresholds was safe in our preterm babies. Interestingly, we're going back to our discussion yesterday about ROP, there was actually no statistically significant difference in ROP comparing both groups. And I'll come back to what the hemoglobin levels actually were later on. Evidence for volumes, I put this in as a very brief slide because it's really extremely limited. We've got several formulae that may tell us how much blood to give to or how much red cells to give to a baby to get your desired increase in hemoglobin concentration or hematocrit. Any formula relies on having a constant hematocrit in your donor red cells, which we know we don't all have, and may vary between countries as well. Roughly for a 1 kilo infant, you'd expect if you gave 15 mils per kilo of blood, you might increase your hemoglobin by 3 grams per deciliter or 30 grams per litre. And so most of us go for that sort of volume. Just going to show you some survey data that you may or may not have seen. Tail end of the pandemic, 2020, late 2020, but we asked tertiary neonatal units in a variety of different European countries to tell us about their transfusion practices. Overall response rate of 57%, which is not bad for countries coming out of a pandemic who had a lot of other things to deal with at the time. A median response rate per country of 84%. And I'm just going to show you the spread of responses because it's quite interesting to see how the NICUs are structured across Europe. You've got some countries, like countries in Northern Europe, where the response rates were really high, but actually they have a lot of centralization and they have relatively few units where they're big units and they do a lot of centralized care. Whereas if you look down towards Central Europe and the UK, we have a lot more devolved systems. If you count that as individual responses, then actually although the response rates are very high from the Northern European countries, we see a big skew of number of responses from the Central European, the more devolved units, which does go on to affect the results a little bit as we've got a very high German skew, which is not necessarily a bad thing. And we talked about doing kind of weighted analyses, but we thought it would be a little bit too much for survey data, which would probably have a bit of a German skew to these results. This is not quite the beautiful violin plot that's in the paper because we unfortunately last month spotted a small analysis mistake. So this is the corrected analysis without the beautifaction of the rest of the team. But this is done together with a large team of neonatologists and transfusion experts across Europe as part of the Neonatal Transfusion Network. So I definitely can't take sole credit for this. Oh, thank you. A pointer has appeared. So we asked people what threshold would they use to transfuse red cells to babies at varying clinical states. So in the light blue, you've got babies who are in air. The red are babies in low flow oxygen. The kind of turquoise is non-invasive ventilation with less than 30% oxygen, and non-invasive ventilation with more than 30% oxygen. And in the green, you've got your ventilated babies. So on the x-axis, we've got the age of the baby in weeks, and on the y-axis, we've got the threshold in hemoglobin in grams per litre. So as you can see, people felt, and this is in line as well with the guidance used in the major transfusion trials, that the younger your baby was since birth, regardless of gestation, you felt that they probably needed to have a higher hemoglobin concentration, and the sicker generally that your baby was felt to be, so the more respiratory support they were needing, the more hemoglobin you wanted circulating around their body. And if we think back to where the liberal and restrictive thresholds sat, we're sitting probably closer to the more restrictive thresholds, but some people are still transfusing at higher values. We also asked people what rate and volume you transfuse your red cells over. So we asked people how much per kilo are you giving and how fast do you give it? And across the x-axis here, we've got the volume given in mils per kilo, and on the y-axis, you've got the duration in hours. In the UK, we've got really strict guidance that you're not allowed to keep it out of the fridge for more than 4 hours, which is why our responses were capped at 4 hours. But interestingly, that's not the case across Europe. Some people are able to keep it out of the fridge for longer. And most of us are giving between 10 and 20 mils per kilo. We've calculated transfusion rate in mils per kilo per hour, which was not quite as interesting in red cells in terms as it was for platelets. And that's as much as I'm going to step on Dr. Moore's toes at this stage. But we found that some units were transfusing platelets at rates of up to 60 mils per kilo per hour, which into a small preterm brain is relatively alarming. But for red cells, we found it was mostly 10 mils per kilo per hour or less. So we tended to go slower with our red cells than we did with our platelets or our plasma. So touching on to a few controversies now. Transfusions and NEC. We've all heard of transfusion-associated NEC or TRANEC, and we know from the Mohammed study back in 2012 that if you have a transfusion and a episode of NEC within 48 hours of each other, you're more likely to end up, unfortunately, dead or under the surgeon's knife. But delving further into that, is it the anemia that's causing the problem? Is it that you're anemic for a long period of time? You've got maybe hypoperfusion to the gut, you've got relative gut hypoxia, and that's probably not very good for a developing gut with a high metabolic demand on it. Or is it something that's happening with the transfusion itself? Or is it potentially a combination of the two? So Ravi Patel et al. Tried to tease that out back in 2016. They looked retrospectively at 598 babies, and they tried to tease out whether it was the transfusion or whether it was the anemia. And they used a number of statistical models to try and do that. And in their preferred model, they found, of course, that having a lower birth weight was independently associated with developing NEC, which is probably a surprise to absolutely none of us. If you were given a red cell transfusion in a given week, then although the p-value is 0.9, that doesn't reach a level of statistical significance as compared to being exposed to severe anemia within a week. So they felt from this study that actually being exposed to severe anemia with a hemoglobin less than 80 grams per litre within a week was more associated with NEC than receiving a red cell transfusion within a given week. And that's our human evidence, but what about animals? So we know if you take mice and you make them artificially anemic, so you take blood out of them just as we do for babies, then if you compare the gut of a sort of prolonged anemic mouse with a non-anemic mouse, then the endothelium has degraded in that anemic mouse, it becomes more leaky, and they don't develop classical signs of NEC as we'd expect in babies, but they certainly develop gut signs of degradation, of deterioration. And if you were to then compare the inflammatory markers of those mice who are anemic and not transfused versus mice who are anemic and transfused, there is an increase in the inflammatory markers in those who are anemic and transfused as compared to those who are just anemic. So there's some suggestion there that there's contribution from both, that there's potentially a pro-inflammatory effect of transfusing red cells as well as a negative effect of having prolonged anemia. So what about withholding feeds? Most of what we believed about feeds and speed of increase was kind of destroyed by the SIFT trial. So we were wrong there, and we're wrong now as well. Withholding feeds and NEC. So this is a meta-analysis that was done in 2017 that looked at a number of retrospective epoch comparison trials of epochs of withholding feeds versus continuing feeds. A lot of them were really inconclusive in terms of really wide confidence intervals and not individually conclusive. Potentially one of the biggest contributions to this, the Derienzo et al. Trial, were actually very critical of their own conclusions, despite making a major contribution to this meta-analysis. Their main conclusion was actually that if you have a lower starting hematocrit before your transfusion, you're more likely to develop NEC later on. After this meta-analysis, then people started moving more towards withholding feeds. But do we really have a definitive answer without an RCT? So I'd just like to ask you, as a Slido poll to keep you all awake, what would your approach be during transfusion for these babies? So you've got baby A and baby B. Their hemoglobin's probably the same. They're probably the same corrected gestational age. Baby A, he's preterm, he's well grown, he's on high flow. We're in a high flow unit because we love high flow in the UK, but you couldn't change that for CPAP. He's currently fully enterally fed and he's doing quite well. Compared with baby B, who remains ventilated, has some significant growth restriction, also currently fully enterally fed, but is really difficult to cannulate. That may not represent a problem for everybody. In the UK, we do all the cannulas as doctors, so it's very squarely our problem putting 2 cannulas into babies who are tricky to cannulate for a feed withheld transfusion. So what would you do? Remember, baby A is your well-grown baby who's on high flow. Baby B is your IUGR baby who's still ventilated. Well, that's a really interesting spread and actually does reflect a lot of the results of our survey. Anyone else wanting to answer that? So most of you would feed both babies, which is really interesting. Some would feed neither, and there's more willingness to feed the probably perceived bigger, weller baby, and nobody wants to feed the sicker baby as compared to the well baby, which is probably sensible. Well, I'll show you in a slide's time because I'm not actually allowed to choose in our unit at the moment. So when we asked people in our survey, do you withhold enteral feeds during red cell transfusions? Only 30% answered that they always would, and about almost 2/3 said that they never did, which as a European group, this probably reflects what we've just seen in the poll. However, answers are on the way, and this is why I'm not allowed to choose at the moment because we're taking part in the wheat study. This is a study run joint in Australia. I think there's a Canadian contribution as well. And in the UK, looking at babies born less than 30 weeks. We're withholding feeds 4 hours before, during, and 4 hours after transfusion, as comparing with feeding the same volume that they were fed before throughout the transfusion, and looking at rates of NEC and other reverse outcomes before discharge. And to adequately power that, they needed 4,333 babies to be recruited before December 2025. So we've got our work cut out for them. So I've got to answer to our consultants why I've chosen. Moving on to one of the other more controversial topics. What is actually in a bag of red cells that we're giving to these babies? Oops, spoiler alert there. So what we see as clinicians in the UK is you get an adult donor at the top who comes to a blood transfusion centre, and they get fed some tea and biscuits if they're really lucky, and they leave maybe a little bit less replete with red cells. On our units, we see a maybe pale looking baby. They may be having some apneas, some desaturations. We prescribe them a blood transfusion, and some red bags arrive from the laboratory a few hours later. We kindly give them to the nurse who puts the transfusion up, and we get a nice pink baby about 5-6 hours later. And that's pretty much what we see. But actually, there's a lot of work that goes on behind the scenes. We've got an organisation called NHS Blood and Transplant, which coordinates all the donor activity, the processing and the allocation of red cell transfusions, as well as platelets and plasma to the patients. And so is it just a bag of red cells? Are they all the same? Well, the answer is they're probably not, and we're probably processing them very differently country on country. But because as clinicians, we only get a small snapshot of what goes on, we may not pay much attention to what we're transfusing. I'll come back to donors in a minute, but some of the things to consider is storage. How long is it stored for? How is it stored? And when does it expire? Who decides when a unit of red cells can no longer be given to a patient? And are there certain patients where we should be giving fresh donations? Are there some where it's okay to store it for longer? Some units have volume reduction, and some places have particularly platelet hyperconcentrate that can be given. We don't in the UK. Different hematocrits in different transfused units of blood. We do aliquoting in the UK, where a donor may come in, their blood will be deemed as safe for babies as it doesn't have CMV in it, and may then be broken down into smaller packs, and those packs can then be reserved to be given to the same baby. So if we have one baby who we think is going to be needing multiple transfusions, we can reduce their donor exposure by using packs from the same donor. So sometimes if we talk to the lab, then we can have that happen. Cells are often washed and leukodepleted, and they're done in various different ways in different countries. And the issue of irradiation is very interesting. We don't irradiate a lot of our red cell transfusions in the UK, but I know some places do. And there was a study recently looking at how freshly you irradiate your red cells as compared with sustained increase in hemoglobin concentration. And they found that if you transfused a baby with freshly irradiated red cells, your hemoglobin increase lasts for longer than if you have stored later irradiated red cells and given to a baby. So there's potentially a lot more in thinking about what we're actually giving to these babies in that bag of red cells that arrives from the lab. Going back to donors, so a really interesting study again by Ravi Patel recently in the USA looked at the outcome of sex of donor so looked at the sex of donor compared to the outcome that happened for babies, and found that actually if you gave a baby a red cell transfusion from a female donor compared to a male donor, and an older donor as compared to a younger donor, the outcomes in terms of major complications were better. Now that improvement kind of faded away the more transfusions you gave. So they concluded it may be better to give fewer transfusions and older female donors if you're keen. If there's anyone out there who's older and female and wants to give blood, then you might be very beneficial to babies. But why is that? So there's always going to be biological differences between men and women. Females often have a lower hemoglobin concentration in their blood than males. Our red cells, if we're of menstrual age, are going to be younger. Often they're male red cells. We sometimes have increased oxygen carrying capacity as compared to male donated red cells. And apparently our red cells break down less during storage. And that may be down to the fact they're probably a little bit younger than some of the circulating male red cells. They also postulated there could be lifestyle factors associated with that. I'm not going to compare men's and women's lifestyles here and get into a debate. There are also variations in health conditions affecting men and women. And we know that if you've got G6PD, then that can affect the red cells that you donate as well. Medications that people are on, we don't automatically stop people from donating based on certain medications. And of course, the blood banking practices as well. But there may be much more information in looking at who this blood actually comes from than we're aware of. Oh, another controversy, diuretics. Who loves a good diuretic? So you're giving a packed red cell transfusion now to an X24-week baby who's now 32 weeks corrected age. He's on high flow, he's got a moderate oxygen requirement. He did an echo last week and there was no signs of failure at all. His current HB, however, is 79 grams per litre. So you've decided as he's on high flow that meets your transfusion criteria. And you're going to give him a red cell transfusion at your standard volume. Now, would you give him diuretics or not? And if you would give him diuretics, when are you going to give them? Now, that's really interesting to see. I think in our unit, we are absolute lovers of diuretics, but I can see it from both sides. Even spread of when to give it as well. So most people wouldn't, but if you would, we can't quite decide when during that transfusion it might be best to give it. I'll just give you a minute to photograph that if you're wanting to. Cool. So concurrent use of diuretics, why or why not? And we've not got much evidence. If we're from the diuretic giving population, then our argument is that we're often giving these babies large volumes of fluid, we're giving them fluid shifts within their body, and so we want to try and mitigate that. A counter argument may actually be that the diuretics take so long to work that you're actually exaggerating that fluid shift by giving them diuretics. So what I mean by that is you're giving them a large increase in volume, you're then giving them diuretics, which take a while to work, and it actually gives them a huge increase in circulating volume and then kind of a rebound decrease, which may be worse than no diuretics at all. One RCT back in 2011, done in Australia, 40 babies only. They were given 1 milligram per kilogram of frusemide or placebo just before a top-up transfusion. And they looked at echo values before, during and after the transfusion and found there was really no difference. But looking at the FiO2 changes, so the group who received the placebo are the ones at the filled in square, and the ones who were given frusemide were the ones with the dotted line. I found there was a slight transient decrease in amount of oxygen that babies needed in the frusemide group as compared to a non-sustained increase in FiO2 in the placebo group. Now, some people look at that and say, yeah, I'm absolutely right to give diuretics. I'm going to carry on doing that because it's fantastic practice. And other people say, well, look, that's a 4% change in FiO2. That's absolutely nothing. It's not worth me risking giving the baby diuretics when I know that there's effects on the kidneys and on the rest of the body. So we still don't have a conclusion there. More research required. I don't think this slide is controversial at all. I think we've touched on it yesterday as well, but it should potentially be one of the mainstays of our treatments in terms of red cell transfusion, is blood sparing methods and trying not to need to transfuse these babies. The big one mentioned yesterday, of course, the deferred cord clamping, allowing the blood to flow from placenta to baby. But some of that blood will still remain in the cord and the placenta. So could we actually use some of that blood for the initial blood tests we need for the baby, for instance, the group and Coombs test, initial blood cultures and things? And we've started doing that in Oxford to reduce the amount of blood we're taking out of these babies in the first couple of days. Small volume sampling, there's a machine I think we've demonstrated the last couple of days upstairs, using a very small volume of blood to get a white cell differential, which is potentially useful in thinking about infections, or not if you listen to the talk on Wednesday. We've got a slightly different machine in Oxford that takes 20 micromils of blood and will give you a full blood count. So you'll get a hemoglobin, a white cell count and a platelet count. Which is great, but what you have to do is put a small sample into one of these mini vets, and then the doctor or nurse taking the sample has to do a dilution themselves and then put it into the machine. And that's where we're finding there's actually a lot of problems. So a lot of the time we get a result that's clinically compatible and we think, yeah, that's great, we'll go with it. And then sometimes you get something which is just so odd that you end up sending a sample to the lab. And so we're not completely reduced our sampling with that. Sometimes we find we're actually doing more to confirm or refute the results we've just seen. The Netherlands and Italy are starting cord blood banking, so either cord blood banking for that same baby or for other babies, which means that we'd be giving them hemoglobin F rather than adult hemoglobin. Routine bloods. We found out yesterday that we're all really stressed, we're really underpaid, and we're really overworked, yet still we want to do routine bloods on babies sometimes. That we say, well, they should have weekly bloods. Why are you doing the bloods? Because, oh, we haven't done some for a while. Why? Why? Do bloods if you need to, if they're going to change what you're doing to the baby. I'm not going to talk about EPO in depth because I come from a country where we really don't use it, but we did ask about it in the survey, and there's a paper out of Germany coming soon about their use of EPO. And iron supplementation, a lot of us do it, but actually very few of us comply with the ESPGHAN guidance, so we potentially could do it better. Just putting ourselves back in the last 5 minutes, does one size fit all? So this is the British Society for Haematology guidance, very similar to the restrictive threshold guidance from the 2 big studies that came out recently. And is this right for most babies? Probably yes. Is it right for absolutely everybody? Is it the only thing that we should be looking at when we're making a decision as to whether to transfuse red cells? And where we started with that question is, what actually were the hemoglobin concentrations of the babies in these big studies? So this is the ethno trial on the right here, and this is the hematocrits of the babies throughout the trial in the liberal versus the restrictive threshold group. And you can see that actually the hematocrits over time were not only fairly similar between both groups, but actually reasonably high. So if you divide 30 by 3 to get a hemoglobin of 10, most of them sit between 10 and 13 for the duration of their stay, which is actually well away from those lower restrictive thresholds. Similar in the top study. So in the top graph on the left-hand side, you've got the pre-transfusion hemoglobin levels, where you can see a clear difference between the 2 groups. But in the bottom graph, you can see what the actual whole group's hemoglobin concentration was over the time of the study. And again, even in their lower threshold groups, although there was a true difference between the 2 groups, the babies still sat around 10, so 100 grams per litre of hemoglobin. So not sitting right on those thresholds. Where you'd be considering transfusion. And if you think back to what happens in terms of development of blood and hemoglobin, you start in your fetal life producing all your blood in your yolk sac, the liver gradually takes over, and then it's not until about 30 weeks that we're actually producing our red cells in our bone marrow as we would as an adult. And we know from previous older studies published back in the 90s that generally the more preterm you are, the lower your starting hemoglobin concentration. So I sought out to ask the question, in Oxford, what's happening at the moment? What are our babies' hemoglobin trajectories doing? And so we found babies born between 2018 to 2020, less than 32 weeks. There was almost 800 of them. And the first interesting thing we found was that most of them are getting 30 to 40 blood tests. One poor baby got 527 measurements of hemoglobin during their stay. And I'd say that's probably not completely unheard of anywhere. We had a skew towards the higher gestational age. We had an extra bump at 26, 27 weeks, and that's because our level 2 units will send us anyone born under 26, 27 weeks, and we'll look after the older ones. So that's our general population. And I was expecting to see that our starting hemoglobins had a trend towards a higher hemoglobin value in an older gestation baby, but I wasn't expecting to see it line up almost exactly. And this is unpublished data at the moment. We're working on how to put it together for a poster or a paper. But I just thought it'd be very interesting to show you that trend, which we didn't see in the 90s down to 22, 23 weekers because we didn't look after them, is persisting down to our 22, 23, 24 weekers, that they are starting with lower hemoglobin values. And definitely, as in the studies, our hemoglobin values for babies trended to be between 100 and 120. I would discard those dotted lines down the bottom because they're for our 29 and 31 weekers. And if you're still in hospital at 15 weeks after being born at 30 weeks, something's going wrong. And these are small numbers of babies. So what about our special cases? We've all seen babies you could compare two on the unit, both having clusters of apneas, desaturations, not quite well, both look a bit pale. You give both of them a transfusion, one of them stabilizes beautifully, and the other one, you might as well not have bothered. So how can we identify these babies who actually would really benefit from a transfusion? Is hemoglobin concentration the only thing that we could look at? And so what we started by doing is initially this project was going to be looking at characterizing adverse events during transfusion. So we actually, well, we never report our adverse events. So we're missing them all. What actually happens during these transfusions? So that's what we set out to do. And what we did was we recorded babies' vital signs, their heart rate, their breathing rate, apnea rate, and saturations before, during, and after red cell transfusions. We didn't alter our practice. We just monitored what they were doing at the moment. And then we plotted these. I'm just going to show you some really brief examples here, which are quite interesting. Small numbers at the moment, so we can't draw any particularly exciting conclusions from it. But these are the heart rate traces of babies before a transfusion. The 0 is when the transfusion starts. The second dotted line is when the transfusion ends. Now, as seen in previous papers, some babies show us an increase in heart rate at the start of a red cell transfusion. We're not quite sure why that is. But as we started looking at this data, thinking, where are these adverse reactions? How are we going to characterize them? What are they? Do we have any? We noticed something else that, here we go, in baby number 10 over here, so second down on the right, you can see that this baby is really clustering with his bradycardias before the transfusion and actually during the start. And then towards the end, something seems to happen to make this baby more stable. And we see it again over here. With this baby, lots of clusters of bradycardias, and then suddenly something happens and he becomes a little bit more stable. And then you can see other babies, like the one down here on the right, who seems to be having constant levels of bradycardias throughout and after the transfusion. It doesn't seem to make a difference at all. So looking at this, it's not conclusive, but it is quite interesting. And one of our next steps after collecting a bit more data is going to be to mathematically classify these babies into responders and non-responders, and then look back at the characteristics of these babies. Is there something we can tell about babies who benefit more than others in terms of stability from a transfusion? Is there anything else apart from just hemoglobin concentration that we can use to guide our transfusion practices? And we're doing this collaboratively with a group in Berlin and the Netherlands as well, who are into big data. So lots and lots of collaborative work. And I'm just going to leave you with a few key points. So restrictive thresholds are probably safe in most babies. Inclusion in terms of including feeds and diuretics, we don't have any conclusive evidence yet. It's really important to think more about what we're transfusing, I think, particularly in the next few years. This is the realms of research, so we can't phone up our local blood bank and say, I'd like a 65-year-old female's red cells for my baby, please, and I will not accept anyone else, because they'll probably just get cross. Prevention is probably better than cure, so minimising our phlebotomy losses is really, really important. And just thinking towards the future, where the hemoglobin concentration is actually the only tool we can use to decide when to transfuse, or whether there's going to be other things as well. I'd like to thank all the people I've worked with from the Neonatal Transfusion Network and locally in Oxford, putting together all this data, and the 99 NICU team for inviting me. Thank you very much. Any questions?